Hi, my name is Colleen Campbell, and today we will be going over pelvic ultrasound. The goals of pelvic ultrasound will be to understand the planes of pelvic ultrasound, to identify the bladder anterior, to identify the position of the uterus, and within the uterus to identify the echogenic endometrium and the myometrium. Finally, we will identify the ovaries if possible. First, we must understand the imaging planes that we use in pelvic ultrasound. The transverse view is used in transabdominal scanning when we place the marker dot to the patient's right. We will then be able to see the uterus on the left and the right sides. In the longitudinal or sagittal view, we place our marker dot upward, and we can identify structures from superior to inferior. Finally, in the coronal view, we can place our marker dot on the patient's right side and upward to obtain coronal views of the uterus. For transabdominal probe and positioning, we first start with the phased or curvilinear array transducer. We place the probe in the OB or GYN preset, and we put the probe directly over the pubic symphysis in transverse orientation with a marker dot to the patient's right. Next, we fan the probe inferior into the pelvis. For best visualization of the uterus, a full bladder can be used as an acoustic window. This is what we see in a relatively empty bladder in a transabdominal transverse view of the uterus. We will be able to see here the thin endometrial stripe, or thicker depending on what period of the cycle we are in, and we will be able to see the right side and the left side of the uterus. To get a better idea of what we will cover today, let's go over the anatomy of the uterus. First, what we will see is the uterine fundus at the top of our view. The uterine cavity leads to the bulb-like cervix, and finally, that connects with the muscular vagina. The stripe of the vagina may be visualized on transabdominal ultrasound. We can differentiate the endometrium and the myometrium of the uterus, as the endometrium is hyperechoic in comparison to the myometrium. Lateral to the uterus, we can often identify the ovaries in their position medial and anterior to the internal iliac artery and vein. This is a view of where the ovaries lie in respect to the uterus in the transabdominal transverse view of the uterus. To find the ovaries, we oftentimes follow the lateral aspect of the uterus, called the corneal flare, out to the relatively hypoechoic ovary. Sometimes we can identify the ovaries actually posterior to the uterus, as in this clip. If we look at the structures in the pelvis from anterior to posterior, what we first see is the bony pubic symphysis. Next, we see the bladder, which is the anechoic fluid-filled structure. The fundus of the uterus will oftentimes be seen wrapping anterior to the top of the bladder. There will be a concavity seen between the cervix and uterus in an anteroverted uterus. We can identify a hyperechoic vaginal stripe, which leads to the cervix, and the hyperechoic stripe of the endometrium. Behind the uterus and anterior to the rectum, we find the potential space in the pouch of Douglas. This is sometimes filled with anechoic fluid in pathologic states. Finally, posterior to all of these structures, we will again find the bony sacrum. To get a better idea of what we will see in a sagittal view of the uterus, from superior to inferior, we will first find the fundus of the uterus flexing over the anechoic bladder. If we follow the fundus of the uterus down, we will see the cervix, and the cervix will be connected to the vaginal stripe of the vagina, which can be identified as the hyperechoic structure. If we want to watch it live, we will again notice where all of these structures lie in the sagittal view of the pelvis. This is another example of the view we will find in the hyperechoic vaginal stripe we will see posterior to the anechoic bladder. This is an example of an abnormal pelvis when we look at the uterus in an anteroverted orientation in a transabdominal sagittal view. What we first will notice is the fundus of the uterus behind the anechoic bladder. Next, behind the cervix, we will notice the anechoic space, which represents the pouch of Douglas. This space is oftentimes seen behind the cervix, and this represents an abnormal amount of free fluid within the pelvis. We commonly see a small amount of free fluid, less than a centimeter, at the time of ovulation or menstruation in normal, healthy women. More than a centimeter would be considered to be pathologic free fluid within the pelvis. This is another example of transabdominal sagittal view of the uterus and ovaries, and where we may find the ovaries posterior to the uterus in a sagittal view. For the transvaginal views, we start with an empty bladder, and we place our marker dot anterior, which represents the sagittal view of the uterus. If we place our marker dot to the right, or 90 degrees counterclockwise, this is the coronal view of the uterus. We first start with the endocavity probe and cover it with a gel-filled probe cover, and then place sterile Surgilube on the exterior portion of the probe cover. This helps us to identify all structures in great detail, and we are able to see pregnancies at 1 week sooner than we can transabdominally, and we are able to oftentimes see fetal heart tones at 6 weeks gestational age. To review the planes of ultrasound scanning for the transvaginal views, we mostly use the sagittal, where we place our marker dot anterior, which is also called the longitudinal view of the uterus, or we use the coronal view, which is when our marker dot is to the patient's right. These lines represent the planes in which we divide the body up into. First is transverse, when we do a transabdominal view. Second is sagittal, when we do a transabdominal or transvaginal view. And third, we have the coronal view, which is mostly used in transvaginal views of the pelvis. For the sagittal endovaginal view, we place our marker dot anterior. We place the probe just within the introitus and pause to look at the screen to identify the cervix before we proceed slowly. As we identify the cervix, we slowly enter into the inner end to expand our view, and we notice the cervix is posterior. We then fan from the patient's right to left to find the endometrium of the uterus. Once we find the endometrium, we follow this stripe anterior to identify the fundus of the uterus. More anterior, we will identify the bladder as an anechoic structure, and we will be able to identify the position of the uterus. In terms of positioning of the uterus, most women, 85%, have a uterus which is anteroverted and anteroflexed. So the normal position of the uterus would be to fold over the bladder anterior, and there would be a concave structure between the cervix and the bladder. In a retroverted uterus, the uterus will flex posterior towards the rectum. In a retroverted uterus, that concave structure between the cervix and the bladder will then become convex. This is what a typical uterus may look like on transvaginal ultrasound. The bladder will be hypoechoic and anterior. And posterior to that, we will see the fundus of the uterus. Next, we will identify the endometrial stripe, and most posterior, we will find the cervix, which will be right next to the probe in position. Let's go over the anatomy of a sagittal view of the uterus in transvaginal. Again, most anterior, we will see the bladder. The fundus will be right next to the bladder and just behind it. Posterior to the fundus, we will find the cervix. And posterior to the cervix, we will see echogenic bowel. And this is an example of what we will see in a retroverted uterus, which may represent 15% of women. Here, we will see that the cervix is actually anterior to the fundus. We can follow the endometrial stripe posterior to find the fundus of the uterus. This is an example of an abnormal retroverted uterus. What we see anterior is we see the cervix and we see a thin endometrial stripe leading to the fundus of the uterus. What is abnormal about this scan is we see large pockets of anechoic fluid anterior and posterior to the uterus, which represents free fluid. We also notice the bowel peristalsing within free fluid, which is always abnormal. This may be caused by a ruptured ectopic pregnancy or a ruptured ovarian cyst or other pathology within the pelvis. If we want to take a closer look at the cervix, we will notice several hypoechoic structures which are within the cervix, and these are Nabothean cysts. We can actually measure the length of the cervix in the sagittal view of the uterus and determine if the cervix appears to be thinning during pregnancy. These are the Nabothean cysts, which are normally found within the cervix. For the coronal view of the uterus, we start with the sagittal view at the level of the endometrium. We then place the fundus in the middle of our screen before we slowly rotate the probe 90 degrees counterclockwise. We then fan the probe anterior to posterior very slowly. Next, we identify the ovaries by following the corneal flare laterally. This is what we would see in a coronal view with the marker dot to the right. Endovaginally, we will see the uterus here, midline. Anterior to the uterus, we will see the anechoic bladder. Here we see the endometrial stripe, and this is the patient's right side, and this is the patient's left side. Here we notice a cyst within the ovary, which is anechoic, and this likely represents a corpus luteal cyst. When we look at the endometrium, we will notice that there is a basal hypoechoic layer and a functional layer, which is hyperechoic. The functional layer is what sheds during the cycle. It is composed of a compact layer and the echogenic, thick spongiosum layer. The triple layer that we see here is represented by the two proliferating bands plus the central echogenic canal. Here again, we see another example of endometrial thickness and the endometrial stripe. When we look at the endometrium, we measure the echogenic area in the thickest area in the sagittal view. For the normal menstrual phase, this is only 2 to 4 millimeters thick. When women are in the proliferative phase, it has a trilaminar appearance, which is 5 to 11 millimeters thick. And finally, in the secretory phase, it will become uniformly thick and 7 to 16 millimeters. If we are scanning postmenopausal women, greater than 5 millimeters is considered abnormal. When we look at the myometrium, it should be uniformly hypoechoic, and we will notice anechoic structures with blood flow in them, which represent the arcuate vessels within the myometrium. This is again an example of the endometrium, and this is another example of the endometrium with a foreign body seen, which is echogenic and seems to give off reverberation. This actually is an IUD within the endometrium of the uterus. Sometimes what we see in the endometrium is more exciting than an IUD, such as this little future medical student. When we go on to a look at the myometrium, we will notice the arcuate vessels along the myometrium, and we can put color flow on them to confirm their vascular nature. Sometimes within the myometrium, we will see some irregularities, which may be hyperechoic or hypoechoic, such as this structure. This structure actually represents a calcified fibroid within the myometrium. When we stop this and do a freeze frame, what we notice is this fibroid is so calcified it actually produces shadow like a large gallbladder with a big stone within it. Here again, we see another example of a fibroid within the myometrium. This is the myometrium, this is the endometrium, and again, we see something going on in the endometrium with a heartbeat. Finally, in the adnexa, we notice the ovary. To identify these structures more clearly, I have outlined them here. The fibroid is seen as irregular density in the myometrium. Below this, we see the future medical student, and lateral to this, we see the ovary in the adnexal region. Going on to talk of the ovaries, a normal ovary is 4 by 3 by 2 centimeters. We will find them lying approximately 1 centimeter anterior and medial to the internal iliac artery and vein, although the ovaries are somewhat mobile and they can be in different positions, especially in women who've already had children. The ovaries are moderately echogenic, but usually hypoechoic compared to the surrounding bowel. They are contained within the lateral edge of the broad ligament, and within the ovary we will find scattered small antral follicles, which are 3 to 6 millimeters, and then we will see larger dominant Graafian follicles, which mature to 18 to 24 millimeters. This is an example of where we would find the ovary, which seems easier said than done at times. What we do is we follow the cornea of the uterus laterally. We train our eye for the relatively hypoechoic area of the ovary. Again, we look for the ovaries 1 centimeter anterior and 1 centimeter medial to the internal iliac artery and vein. So if we cannot find the ovary by following the uterus out, the next thing I would suggest is to find the internal iliac artery and vein and then move your probe a centimeter anterior and a centimeter medial. If we cannot find the ovaries in the coronal plane, we can always switch back to the sagittal approach and look for the ovaries posterior to the uterus. Once you find one ovary, go in the exact same plane in the anterior posterior and slowly move across the uterus to find the other ovary. Here we see the relationship of the uterus to the internal iliac artery and vein. On the other side, we notice there is an ovary here and the internal iliac artery and vein, which are approximately a centimeter lateral and posterior to the ovary. Here again, we see the relationship of the internal iliac vein, which is lateral to the ovary. And here we see an example of an ovary with a corpus luteal cyst contained within it. This is an example of an abnormal ovary on the patient's left side right here, and this represents a dermoid cyst within the left side. Here we see the uterus, the thickened endometrial stripe, the free fluid surrounding the uterus and in the pouch of Douglas, and then the abnormal left adnexa. This is another example of an abnormal adnexa. Here we see the uterus. Posterior to the uterus, we see these mixed echogenicity collections behind the uterus and lateral to the uterus on both sides. And this actually represents tubo-ovarian abscess, which may be found posterior to the uterus and on both sides as well. Here again, we see the mapped out tubo-ovarian abscess, and this clearly identifies the importance of ultrasound in diagnosing this infection. Finally, this is another use of pelvic ultrasound. When we see a uterus with no clear dancing baby within it and a little bit of hypoechoic area, which usually represents blood, we become concerned for an ectopic pregnancy. Then we look towards the area of the ovaries, and sometimes we can see a tubal ring with an ectopic pregnancy with actually a heartbeat seen right here. This is one of the main uses of pelvic ultrasound, and this leads to a quick diagnosis of a life-threatening disease. So there are many important uses of pelvic ultrasound, and today we will learn how to see the anatomy of the pelvis. So let's go scan.